to have a dedicated professional, like someone with a registered nurse background or even a licensed mental health professional to advocate and ensure that the patient's rights are being respected and carried out.
Hello, and welcome to Disruptors at Work, an integrated care podcast. We're excited to discuss the failures of deinstitutionalization policies in severe mental illness populations.
Hi, I'm Dr. Samantha Darnell-Tracy, alumni of Cummings Graduate Institute, and the special host for today's episode. And I'm joined today by Crystal Burts, MSW, LCSW, clinician and consultant in private practice. Hi, Crystal.
Well, hello, Dr. Tracy.
Hey.
Thanks for having me.
Of course. I wanted to first provide some historic context before we get into our discussion. Americans diagnosed with severe mental illness were historically committed to state hospitals, colloquially called the asylums. And these facilities were overcrowded, understaffed, at best neglectful, at worst abusive. In the 1960s, the Community Mental Health Act, signed by President Kennedy, closed the state hospitals with the intention of funding community programs to assist former asylum patients. Unfortunately, that funding, community stigma, and increased mental health needs has left those with severe mental illness without resources. And currently, the largest provider for the mentally ill in America is the Department of Corrections. And so today's discussion will be about the needs of patients with severe mental illness, the failures of the deinstitutionalization movement, and the future of care for those with mental illness in an integrated health setting. So, Crystal, I have worked in residential settings, psychiatric residential settings, behavioral health settings since about 2007. Tell us a little bit about your background, how you became involved working with those with severe mental illness.
Absolutely, yes. So back in around 2010, I started my career off in child welfare, and this is in the state of Florida. Most of my career's been between the state of Florida and North Carolina. So I'm working with children, child welfare system, and then I transitioned into the educational system. So I did some school social work, and particularly working with children with severe mental illness. And I ended up transitioning to managed care. So working with the health plans led me to private practice, and just to serve as a space to consult with providers who want to integrate behavioral health into their practices.
Oh, that's wonderful. So lots of experience across the age range and different areas of healthcare. What have you noticed are some of the biggest challenges in that integration, being involved in the managed care side and then seeing it from the clinical side? What are those challenges?
Absolutely. When it comes to patient care and education and involving the patient, I think is really important. I think has been a challenge for the communities to understand what is happening, what services are available, and access, I think, has been a challenge, most importantly, when it comes to treating individuals with severe mental illness. Access and education. There are stigmas that definitely exist today.
I'm going to put a pin in stigma because I want to talk about that a little further in just a bit. But you said a key word that I see as one of the biggest failures of the deinstitutionalization policies, which is access. The intention was for the monies that were going into the state hospitals to then be flooded into the community to provide different services, especially after the development of some of our first generation antipsychotics. those medications were really helpful in the treatment of severe mental illness. And if there would have been access provided in the community, these patients could have had typical experiences. Unfortunately, that's not what happened. You've been in several states. I know in my area that access is very few and far between. What are you seeing?
Yeah, absolutely. Same. Healthcare, and it's unfortunate, today is described as complex. So today, if healthcare is described as complex, meaning difficult to navigate, imagine back then. And that's when I mentioned the level of education or lack thereof that is available. So who is educating the community, the patient, about how to navigate a complex system?
Absolutely. I don't want to speak for everybody, but I imagine you have spent many an hour on the phone with a healthcare system, with however that may be assisting a client, advocating, or prior authorizations. That is a difficult system. And for patients already with struggles, it is not something that is easily managed. We going back to that stigma factor, I know that that has played a part in several communities in preventing the growth of access to healthcare, to systems of care. What stigma have you seen with those with severe mental illness that has hindered their access to care?
Yeah, yeah. There seems to be a stigma when it comes to um, the ability to function, if you will, in the community, or function in a level, whether it comes to access to employment, education, to be a functional citizen in society. There seems to be a stigma that if you have certain diagnoses that you're limited, and so therefore there's not much available to you or for you in society. So that opportunity to integrate individuals who are in need is an important piece. And I think we have a way to go to get there with that integration into the community. Yeah.
Absolutely, you're correct. What I notice, and this gets us into really the crux of the problem, is due to the stigmas, those ideas that maybe somebody is not capable or harmful, dangerous, beyond any other uh, negative connotation to maybe even lazy. That is something I've heard about this population. The results that I notice and have experienced with my patients is then law enforcement becomes involved. Somebody becomes scared because they see somebody acting bizarrely in a public place. Law enforcement becomes involved, and then we start getting charges of trespassing or disturbances. And this leads then to my previous statement of the largest provider is our Department of Corrections, our justice system, our correction system. Law enforcement is usually the first response then to someone with severe mental illness. How can we, as professionals, either navigate that stigma or assist the people who are providing this care getting into these systems?
Yeah,
What,
no, absolutely. And I have to give credit to both states, Florida and North Carolina, the implementation of training law enforcement to be aware of symptoms and signs of individuals who may present with severe mental illness. So I do know and can attest, even way back when, back in 2011, 12 in Florida, where that training was going on, and then also currently today in North Carolina, law enforcement's being trained and certified in addressing mental illness, which I do think is an important factor. However, we still have providers even who may uh, um, not raise their hand to answer the call. So I think it's important to have providers who are equipped and trained in this area. So, but absolutely, you bring up a good point when it comes to um, the law enforcement and in the system. So I will be interested to know where in your area have you seen that? Is that training being offered? Have you seen?
Absolutely. I want to ask if it is CIT or Crisis
Yeah.
Intervention Team.
Yep. The
Absolutely.
crisis
So,
intervention. Yep.
yes, so I am part of our area's CIT. Missouri is really proud of our CIT program. We are pushing this out. I've provided some of the post trainings. I do agree. This is probably the best first line defense we can have, providing education to law enforcement, EMS, fire departments, and I believe we've also started training the dispatch uh, workers in our area to recognize severe mental illness, crisis situations, unsafe situations, maybe somebody who's nonverbal, they're not understanding that they're not being resistant. This is something that they cannot do. Um, and I absolutely agree that training, that education is going to be critical moving forward. I know our jails and prisons are overtaxed. There, I would like to see efforts to basically decriminalize mental illness,
Yeah. Absolutely.
where some of these behaviors, what we as providers would call behaviors, are not criminal actions and can be maybe addressed and treated as such.
Mhm.
In my opinion, I think that would definitely then come back to we need the resources we were promised with deinstitutionalization, these community programs. And I know there are some. I currently work at a certified community behavioral health organization, a CCBHO, and we are still very severely understaffed, underfunded, provided for. What can we and maybe our listeners do to motivate some change, or do you have thoughts on this?
Absolutely getting involved because when this is a matter that when it comes to legislation can definitely influence the level of resources and laws. And so, even when you speak to individuals that are being arrested or now have a criminal record for their mental illness, then what happens to them when they try to integrate into the community? So, then what laws need to be enacted or supported or put in place to help overturn some of those charges, if you will? So, absolutely, community members can get involved to advocate, to understand their representatives' position when it comes to mental health and support those who do have that a part of their campaign.
Yeah, I know in our previous discussion that we've had, Crystal, you talked about transitional coordinators and case managers to help with that transition. And I just loved this idea. I think that would be something that were I the one lobbying to my legislature, I would definitely want to include this. Can you talk a little bit about this coordination?
Absolutely. So imagine, prior to release, or even when the release date is available, that the um, um, person is received or is provided with a case manager or care navigator. And I did fail to mention that I did do some work in the county correctional facility. So there was a role of a care navigator. So to know that having a person to help coordinate, so say medical. So this person might receive medical while they are incarcerated, but then if there are medications or providers that they need to connect with, so imagine having someone to help navigate supports and ensure that the person is insured to even receive the level of care and support that they need, and then case management. So a continued level of support available for
Integrated care, perhaps? That would
integrated
that would be
care.
good.
Ding, ding, ding.
Absolutely. Yes.
Yes, integrated care. And so that person, help navigating this, what could be today if it's complex. So we need individuals that can speak on patients' behalf and help them navigate and coordinate what they need. Um, Absolutely.
Yes. So far, we've discussed the population, those with severe mental illness that with supports could function at a desirable level in society. Having those supports can definitely lead to what we would maybe call typical. Unfortunately, we know, being in the profession, there are those with such severe mental illness that that level may not be appropriate or achievable, at least at this moment. And that's where we start looking into not the law, not the Department of Corrections to house and treat, but potentially long-term treatment facilities that would provide for the best care and the appropriate level of care for somebody with those needs. With the closing of state hospitals nationwide, we lost that. What are your thoughts on implementation of a reinstitutionalization, reopening facilities? I'll speak first if you don't want to be the one to say it.
You know, that question is just spot on. But, when it comes to what we just spoke of, that integrated care model, so just imagine, yes, when you think of mental health institutions, there is some history that may come up with that. And definitely that was then. But today, with the level of integration and where we are at and where healthcare, and when I say health, I'm talking all health, behavioral health, mental health has evolved and advanced. Oh my goodness, the mental institutions or hospitals. So we are going to normalize and destigmatize. We are going to not stigmatize even the word. So we need to shift the language. So the hospitals that we create or that could be created to support will have a level of integration that will hold the institutions and the hospitals accountable, and ensure that there is a level of patient care. And yes, please, I'll pause there, but I appreciate that question. Go ahead. I will be
Yes.
interested to hear your
Well,
response.
I agree with you. I think in our complex healthcare world, as you mentioned, in an integrated sense, because to me, healthcare is not just behavioral health and physical health. Housing is healthcare. Nutrition is healthcare. Having a purpose is healthcare. And so, in a true integrated approach, just thinking of Maslow's hierarchy, if we're counting all of those as healthcare, those are the services that need to be provided to all patients. But obviously, we're talking about a specific population here. I completely agree. My research has been on the horrors of the historic facilities. Those things wouldn't happen in a world with JACO or CARF or CMS standards. All of the boxes we have to check, and as much as we complain about documentation and red tape, those things are there to protect the patients as much as the providers. I believe that in that current setting, we could absolutely have facilities that provided appropriate health care to hopefully rehabilitate and heal to a point of transitioning on, but also provide the supports for those who do not have them and would not have that capacity, but still grant them a fulfilling life, a safe life. We know, going back to that stigma, that we hear things about being scared of those with severe mental illness. But we know more likely the people with severe mental illness are going to be the victims of some sort of crime, not the perpetrator. And that being able to provide that care seems like the best case scenario.
Absolutely.
Unfortunately, I also know that there's a lot of brick and mortar, there's a lot of personnel that would be involved in this. And so money starts ringing up very quickly when we start talking about how would how would we even go about proposing a reinstitutionalization plan. And I think where you mentioned earlier, getting involved with your representatives, getting some funding in that area. Thoughts on that?
Yeah. Yes, no, absolutely. Because I just want to go back to something you said. Um, should an institution serve as a rehabilitation situation? Because individuals with severe mental illness could possibly um, have severed the relationships or the relationships when it comes to their families that they might, have had. And so that can be an opportunity to assist them with building relationships, if you will. So I just wanted to put that out there that that sometimes happen where an individual may not have family to go to. They may because of whatever dynamics or their health could have impacted some relationships directly or indirectly. So therefore, again, building their level of support is important, and so that space can allow that to happen. Was a point I wanted to make for sure.
Absolutely. I agree. Many
Yeah,
bridges are burned
yeah,
in this world, unfortunately. Some of that I think does go back to the stigma and the lack of education we've mentioned multiple times. Even family members don't quite understand sometimes why their loved one is acting or behaving in this way. And it's easier for them to maybe cut that off to protect themselves. Uh, no judgment. It just happens quite frequently.
yeah.
I know kind you have talked a little bit about working with Medicaid reform, things like this. Obviously, there would have to be huge reform with our healthcare systems. And I know that's already in turmoil. The idea of reforming healthcare, it's on the news every day. Medicaid and Medicare do not necessarily provide well for mental health services. I know, for example, Medicare covers 190 days of psychiatric hospitalization in a lifetime. We're looking beyond those kind of scopes for some of our patients who then are without any kind of way of coverage, the lack of coverage completely. Tell me a little bit about your experience with reforming systems, and any suggestions you would have for somebody interested in moving forward with this.
Well, absolutely. With the reform of the state of Florida and both North Carolina, I definitely have been, I want to say it definitely has been an opportunity to support both states when it comes to the reform of Medicaid. I do think that, um, to your question, it's important to be specific when it comes to that very thing of revisiting the what is it going to take, as far as the coverage, especially on the Medicaid level or and Medicare. Again, when it comes to um, um, the laws, when it comes to the policies, it's going to take a level of um, educating, uh, and even when it comes to, and please, I'm in thought when it comes to the individual, because at the end of the day, as yourself, myself, we can advocate. But when it comes to the individual, to understand what is it that they need, families, talking to families and surveying. So going boots on the ground, I can definitely see having that tangible data to support the level of need, to get to where we need to be, on the level of making that change and making that recommendation to Medicaid, to Medicare, to include this level of support when it comes to bringing back institutions, bringing back hospitals that's going to support long term care more than 190 days, longer than that time frame.
You bring up what the individual wants and what maybe their family wants, which leads me to another hot issue here is talking about patients' rights and how historically they've not been respected in terms of institutions, with involuntary commissions and things like that. Moving forward, unfortunately, there would be situations where somebody might have to have an involuntary um, admission as opposed to being committed. We're, like you said, we're changing our language. Uh, I definitely would want to see the patient and the patient's family being involved in this more than historically seen. Uh, you talked about this coordination manager or a navigator. Would this be something that a role that maybe they would be able to take on?
Well, so from transitioning from, say, for an example, incarceration to the community, okay, that's a great role, this care navigator person. But then, yet beyond that, and so for your example, should a patient um, be admitted into a hospital, therefore, case management, to have a dedicated professional, like someone with a registered nurse background or even a licensed mental health professional to advocate and ensure that the patient's rights are being um, respected and carried out. When you talk about family being a part of the patient's treatment, so facilitating these treatment team meetings, and this should all be a part of the patient's treatment, so funded by the insurance plan or whichever method of payment that this is going to be funded by. This should be part of the integration. Having an individual dedicated to the patient to ensure that they are getting their health addressed, improvement, and following the goals that is set forth by the team.
Absolutely. Once again, that key word, integrated care, comes back, and having somebody who can navigate that role. You mentioned maybe a nurse or a behavioral or a healthcare provider. I think that's where a DBT would be DBH would be perfect. A doctor of behavioral health, providing that integrated knowledge of the healthcare systems, the managed care systems, the business side, all of the needs, the family's needs. I think that's spot on, Crystal. Ultimately, the closure of state hospitals, the severely mentally ill have lost their housing, they lost medication, they lost opportunities for therapy and other basic supports. This integrated care model we've been dreaming of here would really help facilitate appropriate levels of care to those who need it. Do you have any final thoughts on that as we wrap up?
When is this going to start, and how can we support your research? Because you've done some good work there when it comes to the historical aspect of this initiative. That you have my support for sure. But if anything, final thoughts are that this is I appreciate the opportunity to even speak on this important matter. And I do hope that more conversations can come of this for sure.
I absolutely hope so too. On that note, I want to say thank you so much for joining me today, Crystal, sharing your insights, your expertise. And I agree. When can we start? I think we already have.
If you enjoyed this episode, don't forget to subscribe and share. Let's keep disrupting healthcare together. Until next time.